Welcome back to another ARPneuro Q&A, and in this episode, you are going to learn how to revolutionize your practice and enhance patient care with ARPneuro Therapy. Today's event is exclusively for healthcare professionals who currently offer ARPneuro Therapy or are considering offering this therapy in the future. It's also going to be led by Dr. Arkfeld today, and Dr. Ted Arkfeld. He's been in practice for 16 plus years, and he runs his own chiropractic clinic in Gaylord, Michigan. He's also a graduate of Northwestern College of Chiropractic, and he sees a variety of patients, including student athletes, and also specializes in concussion management. Dr. Arkfeld is also active as a business consultant to chiropractic clinics and has published several books that serve as a guide for chiropractors who are looking to better understand coding, documentation, and avoid lost revenue, as well as to avoid audits. He hosts a podcast called the Neuro Way to Practice, where he discusses many of these topics. And he's also been using ARPneuro Therapy in his clinic for several years now. And we are so honored to have him once again aboard this event. And so everyone, please welcome Dr. Ted Arkfeld. Good to see you again, sir.
Hey, thanks, Jake. Thanks for the intro. You're so kind. With 16 years, I actually have to modify. It's been 36 years.
Oh my goodness. 36
years. I guess the plastic surgery is working. The Botox is working.
Love it.
All right, guys, I'm going to start off today. I want to tell you one of my favorite patient stories. And this occurred about 2.5 years ago. I've got Melissa that walks into the practice, and I am going into the history. I come walking in, and here's this 43-year-old mother of two, and she's a school teacher, and she's sitting there, and she's got her arms crossed. Just, the body language was like, what am I doing here? And so I said, Melissa, what brings you in today? And she goes, I don't know why I'm here. I have no idea why I'm here. And she's just pissed. I mean, I can't think of a better word to describe this initial interview that I'm doing with this patient. And so I've been dealing with chronic pain patients for a number of years. And I've come across this kind of, being ticked off, really don't want to get their hopes up again. And so I said, well, I just handled it. I said, listen, why are you here? Why are you in my office if you don't want to be here? And she said, well, my sister says if there's anybody that can help me, it's possibly you. And I said, well, I appreciate that. And your sister is a wonderful person. I spoke highly of her sister and everything. I said, so tell me your story. So she tells me that about 1.5 years before she came to see me, Friday afternoon, she gets out of school, is having low back pain, sharp pains on the right side, goes in to see her chiropractor, who she has seen for about 1 year now, and goes in, and it's 4:45. That's important. Okay. It's 4:45. And he doesn't do any history, doesn't do any exams. She tells him that she's having really bad pain in the low back. He puts her down on the table and does a side posture, and the pain was unbearable after that. He goes to do it again, and she goes, no, I can't handle another one. Has a hard time getting off the table, pretty much limps out to her car, gets in her car. The leg is starting to get very weak. She's having numbness and tingling in it. By the time she gets home, she is in unbearable pain and knows something's wrong. Her boyfriend comes and takes her to the ER. They do an MRI, and they find an L5-S1 sequestered disc pinching up against the L4, L5 nerve roots. They transport her immediately down to Saginaw, and she has a surgery to remove that sequestered disc. Immediate relief. She wakes up. She's doing great. Low back is feeling good. No pain in the right leg. Comes back home. For about 3 or 4 days, everything's going great. And then a different kind of pain set in. And this one was almost more debilitating than the one she originally was experiencing. Once again, goes to the ER, and they diagnosed her with having a staph infection in the wound. It had become infected. Once again, back down to Saginaw, St. Mary's Hospital, another surgery to clean out the staph infection and the wound. So this time, there's not the staph pain, but there's another pain replaces it. Now she's in just constant pain. It's a deep, dull ache. And every time she moves, it hurts. She did 2 rounds of physical therapy, 6 weeks each. Didn't help. She did epidural injections. She did 2 of those, and that did not help. And when she went to see the surgeon, the pain management doctor, they said, we have nothing left for you. We don't know what else we can do. The surgery was a success. We got rid of the bad anatomy. We got rid of the staph. We don't have any idea why PT didn't work. We have no idea why epidural didn't work. So she was left this way to live. And this was a very active person, exercised every day, loved teaching, has to be on her feet every day teaching. And during the summer, she actually runs with her boyfriend a barge on Torch Lake in Michigan. And if you've never heard of Torch Lake, you got to Google it because it's a wild time. And she runs the Torch Lake Tiki Bar, and just unbelievable, just a go-getter. Okay. That isn't happening. So she's sitting in front of me, a very depressed, angry individual, can't do, just grinding it out through the day to get through the day, can't exercise. She's starting to gain weight, which is making her very depressed and anxious as well. And she's wanting to know what I'm going to do. And she makes this statement. She goes, I don't know why I'm at another chiropractor's office. The chiropractor did this to me. And I said, well, here's what we're going to do. We're going to look at you differently. I'm going to examine you differently, and we're going to treat you differently. And so I go through and I do my examination. So you can imagine that there is restricted range of motion on all planes of testing. There was weakness in the hamstrings, the glutes, the quads, the dorsiflexors on the right, all 4 out of 5. There was hypoesthesia in the right leg at the L5S1 dermatome. Everything else is pretty good. Obviously, she has a midline incision in the lumbar spine. And so I sit down and I looked her right in the eye, and I said, you are not going to have to live this way. I promise you, you will not have to live this way. And I noticed at the time, just the hint of a tear started to form in her eyes. And I said, I think we can fix you. Now, I know a lot of you that are listening, the doctors out there, you're probably going, what the heck is this guy talking about, using that F word, saying that you're going to fix him? And granted, prior to bringing the RX therapy into my office, I would not have said that. I have treated chronic post-surgical low back pain many times throughout the years. I used to practice in a pain management clinic. I was the only chiropractor. I saw a lot of these. Basically, I used soft tissue and I did coxflexion distraction work. And, I got some results. It depend on numerous factors. If the patient was already a victim to their pain, how bad the structural damage was. And so prior to having the RX into the office, a patient would have came in and I never would have looked them in the eye like I did Melissa. I would have said, well, let's try a course of therapy. Let's do 2 or 3 times a week. Let's do a couple weeks. Let's see what happens. Because I really don't know if I'm going to be able to help you. The structural damage, everything is pretty significant. Well, one of the things that happened when I brought the RX in, and it obviously is a neurological therapy, is that I started studying neurology like crazy. I mean, I went gun-ho on this. Now, I didn't take any Carrick Institute, so I wasn't becoming a functional neurologist. I have the utmost respect for those guys, but the type of neurology that I was trying to learn about was more about how does the RX work? What exactly is the mechanism for that? And it sent me down this journey into receptors and how it affects into the spinal cord, how if we don't have movement going on, how that affects the somatosensory cortex, our sensory homunculus, if you remember that. What is chronic pain? And I can tell you from firsthand experience, I was looking at chronic pain. I was looking for the source of the pain in all the wrong places. And I think a lot of people do. That all changed when I brought the RX in. So there is a peripheralization of pain where there still is a structural problem, but more importantly, there's a centralization of pain. And that's what Melissa was experiencing. And because I had treated other cases so successfully with the RX and with other therapies that we have at our office, the flexion distraction was very important. Normatec compression therapy was very important, and then we have brain tap entrainment therapy. So when I'm talking about a neurological based clinic, we are treating the whole nervous system. And I think sometimes when we get into these musculoskeletal chronic pain patients, we totally forget the neurological aspects of it. And we forget the central nervous system. We forget the autonomic nervous system. So when I told Melissa that she was not going to have to live that way and that I could fix her, all she was looking for was hope. See, nobody had given her any hope up until then. And if I would have came in and said, well, you got a disc problem or you got scar tissue built up around that nerve root, and we got to try to free that, she would have been out the door. She had already heard that. If I would have came in and said, well, you have a subluxation at L4, L5, S1, she would have been out the door because she had already heard that. I had to speak to her differently. I had to examine her differently. And I was very careful in the terminology that I used. For example, when I saw her x-ray and her MRI, yeah, there was degenerative changes at L4, L5, and L5S1. But I couldn't tell her that because one of the things I did not want her to become, I did not want her to become her x-rays or her MRI findings. So instead of saying degenerative, I said, you got deconditioning down here. So my report of findings to her was, first of all, was not a sales pitch at all. What I did is I said, our body is full of receptors, Melissa. You have receptors in your muscles. They're called muscle spindles. You have receptors in your joints. They're called joint receptors. You have receptors in your skin. They're called mechanoreceptors. And right now, those receptors aren't working because you're not moving. And I understand why you're not moving. It hurts to move. And you're fearful because when you go to move, it hurts. And so you do fear avoidance. You move around the pain instead of through it. I said, so what we're going to do is we're going to get those receptors firing up. So really what you are is you're neurologically malnutrition right now. You're neurologically starved. And the reason that you're having the pain, and I brought out the little picture of the sensory homunculus. I said, down here in your lumbar spine, this area is blurred in your sensory homunculus. And so it's not receiving any information because it hurts you. And it hurts because your somatic cortex, somatosensory cortex has lowered the threshold for pain because again, you're not getting the information up there. All right. Is that pure chiropractic or what? See, I don't think we do pinch nerves. I think that we have faulty joints and faulty receptors. And when we do things, we light them up. And so I said, here's what we're going to do. We're going to use an RX machine. It's called ARPneuro, stands for Accelerated Recovery Performance. And it will do just what the name says. And what I did to begin with is I put the pads right alongside the level of the incision. And that was about L4 through S1. And we turned the unit on just so that it was mild stimulation at first. And she was on her stomach, and I did cox flexion distraction technique while the unit was on. So I was doing the adjustment while the unit was on. So what was that accomplishing? Well, first of all, the RX is getting to the muscle spindles, right? It's hitting those muscle spindles at 500 pulses per second. It was hitting the muscle spindles of what muscles? You're right, the multifidus muscle, a stabilizer, main stabilizer of the spine, and it was turning that on. So the other thing that I did is I explained to her that the multifidus muscle is responsible for stability of the spine and posture. It helps with the fight against gravity. It also sends signals directly to the cerebellum, and that's our coordination balance. And she was saying, yeah, I feel uncoordinated. I feel like when I'm walking, sometimes I'm going to trip because it just, my right foot just doesn't feel there. And so we're going to solve that problem. So I got her going with the RX. And then when doing the cox flexion distraction, we're moving those joints in a very safe and effective manner. And I did 3 sets of 5 reps, flexion distraction. And then I would do lateral bending with that. And then I would do little rotary movements. We did that 3 times a week for the first 2 weeks. After the first 2 weeks, she was sleeping through the night. She was also able to stand at work with a 50% reduction in her pain. The first night she came in, or the first day she came in after sleeping through the night, she started crying and said, I haven't slept the full night since this whole nightmare began. And she goes, this is wonderful. I said, well, we're not done yet. We're just getting started. So then we progressed and we started doing the actual active rehab part. I'm going to give you a little tip right now. The coding. So she was a new patient. The severity of the case dictated that it was a 99204 evaluation and management code. So I billed that out and I got paid for it. And then with the manipulations, it was 98941 because I was doing lumbar spine and I was also doing SI joint and sacral. Okay, so 3 to 4 area adjustment. At first, just with the flexion distraction and the RX unit, I was doing muscle. I did 97014 electrical stimulation, and then when we started to have her actually do active, we went to 97110 therapeutic exercises, 1 unit just to begin with. So what did that consist of? So the first thing that we had her do is we had the pads on the lumbar spine again, and I would have her just do sit to stand. 4 sets of 5, normal polarity, 4 sets of 5, reverse polarity. From there, we graduated up to toe touches. 4 sets of 5, reverse 4 sets of 5. And yes, we're increasing the intensity in between each rep. Then at that point, we went to squats and we got her through all the squats and she was doing great. And then I got real creative. I started doing, having her stand on a full Bosu ball because we had to get the balance and coordination going. But the other thing I wanted is I wanted those muscle spindles and all those muscles in those joints. I wanted to hit all the different angles. And the only way you could do that is by an uneven platform. So we did the Bosu ball with the RX on it, increasing the intensity, and just had her stand and move. And that's when the biggest breakthrough came in. I mean, her pain was great, but that's when she was able to start going back to the gym. At that level, when I was doing the Bosu ball, that was 97112 neuromuscular re-education. And the reason I could use that code is that when I did the initial evaluation, I had her do a squat and I had her do balance testing and I had her try to do single leg balance and she failed miserably. 97112 neuromuscular re-education is to restore proprioception for any balance problems for seated or standing postures. So I met the code easily. So by the time we were progressing through and I saw her I saw her for about, I would say, 3 to 4 months, and I was using either therapeutic exercises 2 units or a therapeutic exercise and neuromuscular re-ed 1 unit each on every visit. I'll never forget the last time that she came in. She came in and she said she'd been back. She'd been back to work. No, no issues, standing full day. She had been back to the gym working out. She was back walking on a daily basis. She was able to sleep through the night, and she just broke down. She started crying in my in my reception area, and came and gave me a big hug. I've been in practice at that time. That was for 34 years. And that's why I became a chiropractor. I became a chiropractor because I watched my dad go through chronic pain, 3 spinal fusions. You can hear the story in the Neuro Way to Practice podcast, but 3 spinal fusions. And I didn't have, well, I was too young, first of all, but he was still alive after I graduated from chiropractic school, but I didn't have an RX unit for him. Uh, the reason I'm doing this right now is that I realize that I have to expand what I'm doing. There's only so much of me to go around, but we have got to start helping these people. If you want a little niche in your practice, chronic pain post-surgical is the niche. See, they just been tossed aside, and they've been given no answers. And if you are an ARPneuro provider, you have the answers. So you know what Melissa did? She was so happy. She bought a PRS unit, and then she referred her daughter in who had surgery on her knee, a high school girl, gone through a couple rounds of PT, still having knee pain. Well, here's the secret, guys. When there's a failed surgery like that, and if you ask the orthopedic surgeon, they're going to say, well, I did a good job. I got rid of the bad anatomy. If you ask the PT, they go, well, we did all that we could. They did. Absolutely. Okay. They did their job. Here's the issue though. They're looking at a neurological problem and they're trying to rehab it through an orthopedic method. It'll never get done. Everything is neurological, at least the way I see things, and so with, again, with the RX, with the Normatec, with the Brain Tap, we get amazing results. So now, over this last 4 years, like I said, I have been just studying and studying like crazy, taking course after course on movement, neurological aspects, the whole works. And I came up with the Neuro Way to Practice. It's the Neuro Way to Practice program. In my very humble opinion, I think that it's the way chiropractic was. They just didn't know. I mean, we don't have the same terminology, but I was reading the AK manual, the one we used when I was at Northwestern for muscle testing. I was reading that the other night. It was written in 1981 by Dr. George Goodhart. Everything that that he was saying in there about it still holds true. It's the Neuro Way to Practice. The muscle testing, the muscle spindles, proprioception, all that. It was all there. But I think we've just kind of gotten away from it unless you're an art provider. I love the RX has absolutely changed my practice. It's changed my life. I could go on and tell more and more stories, but I have a Neuro Way to Practice program. And that is what I want you to consider. If you go onto the website there, so here's what it is. The Clinical Genius program, if you like the story I told about Melissa, that's what the Clinical Genius program is. That module is all case stories where I go over the story, I go over the history, the examination findings, the diagnosis and the treatments, and what we did and the outcomes. So that's Clinical Genius. As Jake said, I got into concussions. Prior to COVID, I was seeing 40 to 45 sports related concussions per year. In certain states, the local high school athletic association has special concussion insurance. It pays 100% of the bill. Concussions, like chronic pain, are so rewarding, and they're not hard. Okay. You do not have to be a functional neurologist to treat 95% of them. And one of the main factors of getting the RX was because it has a wonderful concussion protocol in there that is just lights out. So there is treatment for a concussion, and chiropractors are uniquely situated with some training. And we have a concussion genius program, by the way. We also have one called stretching. So for many of you that are in larger cities, you probably have heard of Stretch Lab and Stretch Zones and these assisted stretching. And I've gone to these and they're wonderful. But I thought I can do this in my own clinic and bill for it or make it a cash program. And so we developed the stretching program. The N at the end is for neurology because we have a neurological twist to that. And over the last few months, we have redid our whole program. I've got to reshoot the videos in the stretching program, but I started using the PRS units for our stretching. It's unbelievable. We are getting, the feedback. I say I'm even speechless. I did 2 patients today, and my staff did 2 patients today using the protocol, and you can make it a cash program. That's what I recommend. And so you can keep patients in your office instead of going to Stretch Lab and Stretch Zones, keep them in your office. And it goes hand in hand with the adjustment. So we got that program. There's another one that I will be developing, and I am going to be, I got to shoot videos and everything. And it's the neurological, ARPneuro rehab, post-surgical rehab, because something else has happened. I am starting to see patients that are bypassing PT altogether after they have surgery, and they're coming to see me right away. They start their post-surgical rehab with me immediately. And again, before the RX and PRS hit our office, I never would have done that. I wasn't trained to do that. Well, we do it now, and so I want to train you guys how to do it. So what I want you to do, take a look at the Neuro Way to Practice program website. And if you go there, don't get your credit cards out. Okay. I do not want you paying anything through the website right now. You're going to be enticed to do it, but don't, because I want to talk to you first. If you are interested in these programs and how to use the RX and PRS more effectively and to get paid. It's one thing to get great clinical outcomes and set yourself apart from everybody else, and you will, but you need to be reimbursed for it. And I definitely can help you with that. What I want you to do, I want you to send me an email at ted@theneurowaytopractice.com. Okay. Send me an email. I want to schedule a time to talk to you about your practice. I want to learn about your practice. Okay. And because everybody is so different. And then I can guide you on which of the modules that I would recommend for you. Right now, each of the modules costs $500. I'm going to give all ARPneuro clients an unbelievable discount. You get to pick 3 for $500, and then I'm going to work with you. And we can do 1 time a week phone calls or videos or whatever, and I'll work through you on the clinical aspects of implementing RX and the PRS into your offices. And again, I use my practice as really a laboratory. And so I test it all out there, and I've got a lot of things that I want to show because it really helps people. All right, Jake.
Wow. That's compelling stuff as normal. And you taught me something new in a really unique way. You said neurologically malnourished, and then you went into why that was, and absolutely love it. I do have one question.
Yeah.
I have a lot of questions, but one in particular, because you talked about a condition of concussion. You went into Melissa. From your experience in your practice, what have you found as far as being like the most successful conditions that you've used the ARP therapy with, that you've treated patients?
I'd say there's 3, and these are not necessarily in any particular order, but the patients that are in chronic pain post-surgery and they've been abandoned by everybody, with the RX and PRS as well to be used at home. Unbelievable. Really making a difference. Concussions, same thing. We are unbelievable with concussions. But there's one that recently has just reared its ugly head, and I think it's because it's springtime and people are starting to get out. Plantar fasciitis. We are kicking butt on plantar fasciitis. People have gone to podiatrists. They've been doing the rolling on the Coke bottles or the cans, doing the ice, buying those stretching contraptions, and they're no better. And we've developed a whole examination flow. And I'll give you a secret. You better be doing foot baths. I've talked to a couple ARPneuro clients, and I said, "Are you doing foot baths?" And they go, "Well, no." Well, you're missing it then.
Yeah.
So the foot bath is really to get the symptoms under control so that they trust you. You know, a lot of times you got about 3 visits before they trust you and they buy in to what you're going to want them to do. And you can accomplish that with the foot bath. Shin splints is another. The runners and everything.
Yeah.
With the RX, we are lights out with shin splints.
Wow. And is that also using the foot bath?
Using the foot bath and then using blood flow and then searching, doing the scan to see what muscle lights up. You know, the thing is, Jake, you know this, sometimes it's where you don't think it should be, right?
Very true. Yeah.
That's where, as chiropractors, we have always prided ourselves as being the guys that find the cause of the problem. Unless you have an RX and using the RX appropriately, you're not finding the cause of the problem.
And I'm sure a lot of doctors are going to have this question because there's going to be others who take insurance. Is this something that you found that you're getting a lot of reimbursement for with these conditions?
I am. But here's where the reimbursement really comes from globally, is that the patients find value in it. So even if they don't have coverage for the codes that we're using, they'll pay out of their pocket. We got Medicare patients who'll pay me $65 for the service. Nice. We got cash patients that'll pay $65 for the service. Now, that's what I charge in my area. You know, your area could maybe be less, it could be more, but when you start getting results, they will pay. They will absolutely value what you have to offer. And they will refer. Absolutely.
And again, like you said, this is a technique. It's not just having the codes, it's being able to know how to use the codes. And that's where it's probably good to go through you and learn the procedures of the techniques of how you're going to get reimbursed.
Yeah. You know, a couple of weeks ago, we were on a phone call with a young doctor out in Portland, and he goes, "Well, what are the codes?" Everybody always wants to know the codes. And I still get compliance clients calling me up or emailing me and go, "Well, what code should I use here?" And I understand where they're coming from. So it's more than the codes. You've got to have your history. You got to have your exam. You've got to have diagnostics that you run. And all that leads into your proper diagnosis to determine what would be the most appropriate treatment. And then you've got to link the diagnosis with the appropriate code in order to get reimbursed. And so back in 2007, I became one of the first chiropractors in the country. I think there was only 2 others at the time that became a certified professional coder. And I know you doctors go, "Oh God, that was boring." And I was with you at that time, but I absolutely love coding because it's how we get paid.
Sure.
You know, it's the rules. And if you use those rules, I mean, and that's what I want to share. So it's a lot more than just knowing the codes. You got to build everything up. And I'm trying to build it up so number one, you're getting paid. Number 2, that you're establishing medical necessity so you don't have to go through any audits or anything like that.
Wonderful stuff as always, Dr. Arkfeld. Appreciate it. I know people are going to have more questions. I want to put this back up here for you just so they can see this. So neurowaytopractice.com. If you want to email him with any questions, it's just ted@neurowaytopractice.com. And, in the meantime, if you have any questions for us, you can always go to info@arpneuro.com. as always. But Dr. Ted, thank you so much for your time.
You're welcome.
And it's always a pleasure. And once again, everybody who's watching in, thank you for being here today. And feel free to reach out to us and check out neurowaytopractice.com.
All right. Thanks, Jake. Thank you, everybody.
Take care, everyone.